approved in the adjuvant setting, this drug would be used, and then some patients would progress still. No drug is perfect, and resistance does develop to EGFR inhibitors, and that would then require more research to find drugs that work in the more resistant settings. Some of these patients might end up getting chemotherapy, maybe combinations of targeted therapies. Often recurrence with an EGFR inhibitor is seen with a c-MET amplification, so that or EGFR receptor amplification. Maybe even immunotherapy finds its way into the EGFR setting. There are some data to suggest that some of the combinations, such as bevacizumab plus atezolizumab with chemo, work in EGFR mutated patients. So a lot of possibilities there. Well, based on these data, I think testing needs to be done in all patients. Everyone with lung cancer, certainly the non-squamous, but I would say because of some of the crossover, I would say everyone with non-small cell lung cancer should have molecular profiling these days, not just for EGFR, but for the other 8 to 9 molecular abnormalities that we can study. Certainly in the early stage setting, these ADAURA data suggest that we need to know at the time of surgery, who has EGFR or not because of this treatment paradigm. You're asking to use it even earlier, in neoadjuvant settings. I would say yes. I think right now I would stick, if you're using immunotherapy, with what we call the EGFR wild type population, patients without EGFR mutations. Someday there might be ways to combine things together. But right now, I think in the targeted setting, therapy setting, one should use the targeted therapy first. So there's going to be a trial, ADAURA, that's going to look at neoadjuvant EGFR. There's also going to be a trial called LAURA. You're getting a little theme here. And LAURA is going to be in patients with stage 3A disease who have had chemoradiation, looking at this in the adjuvant setting as well. So very exciting to have these tools, and these tools can be used to help patients with lung cancer to live longer with better quality of life. Well, I think, for community oncologists, it's important to molecularly test their patients. We want a personalized therapy. It's been 23 years since EGFR inhibitors were first put into practice. It was 7 years before we even knew about EGFR mutations, and now we know. We also know about ALK, ROS1, NTRK, RET, c-MET, exon 14 skipping, to name a few. You want to try to know all this so that you give the patient the best option and the best drug. And what we're seeing from ADAURA is we want to know about it as early as possible, so that at every treatment juncture, in a shared decision-making format, we can discuss with the patient the best options. Certainly if a targeted therapy has great response rates, why not use that as opposed to chemotherapy, which has much lesser rates and more toxicity? So many more weapons for us as oncologists, myself included, to use as we treat our patients in the clinic. Certainly these oral agents are very nice too in these times where we know chemotherapy is a risk factor for patients should they develop the COVID disease.